Ma'am.
Yes, please.
Yeah, we are connecting on YouTube. Now we are live and we are starting this session with all your permission. Good evening, everyone present here. I am Faraz from Clarnet. Clarnet is very proud to be a part of this session as a digital partner. Clarnet is India's largest live digital CME and doctor-generated learning platform. With all of you, I am presenting a short video on Clarnet. Thank you so much all doctors for watching the video. You all are requested to visit our website, that is www.clarnet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki service, which is medical Wikipedia for doctors only, that you can also read. By taking not much time, I would like to hand over this session to Dr. Nehal Patel, ma'am. Over to you, ma'am. Kindly proceed from here.
Thank you, Faraz. So once again, we are here for our AOPG e-Gurukul PG clinic. We have different case presentations in this, and this time it's a presentation and discussion on respiratory system. So our presenter, Dr. Chinmay Desai, he is third year from Government Medical College, Surat, and we welcome his mentor, Dr. Praful Bambrolia, who is there as an associate professor in Government Medical College, Surat. I'm so much thankful for Team AOP Gujarat, our President Dr. Rakesh Desai, and our Secretary Dr. Kirit Sisodia for the constant support. I welcome here Dr. Yogesh Parikh sir, who is project in charge, and Dr. Baldev Prajapati sir. We were missing you in last few sessions, but you are free again here to help us. And sir is a great teacher and everybody knows him. Myself, and Dr. Prashant are the project coordinator. This time for this presentation, we have two experts who are the best in this pulmonology field. And so I welcome Dr. Hari Mohan Meena sir. Meena sir is assistant professor at Department of Pediatrics, SN Medical College, Jodhpur, and he is secretary of IAP Respiratory Chapter, Rajasthan also. His field of interest is pediatric pulmonology, allergy, and immunology. We also have Dr. Raghuvamsi Sir Reddy. Sir is a fellow in pediatric critical care, pulmonology, and sleep medicine in Australia. He is at present director and consultant at Star Kids Children Hospital, Anantapur, Andhra Pradesh. I welcome both the experts for this session. So I ask Dr. Yogesh Parikh sir to give a welcome note.
Thank you, madam. So thank you for the accepting our invitation, Dr. Hari Mohan and Dr. Reddy sir, and Dr. Baldev Prajapati sir, our great teacher, academician, and our guru. And sorry, we missed last year 2 sessions due to busy schedule, and sir is there. So today's session will be excellent session, and our President Dr. Chinmay is a great orator actually and writer also. So let us congratulate Dr. Chinmay for the great presentation, and our Praful, his mentor, and we also thankful to this Clarnet platform. Thank you very much, madam. Let us start the program.
Yes, so thank you so much, Yogesh sir, and I hand over this platform to Baldev Prajapati sir and Chinmay. We have another PG who has logged in as an IMA Zoom meet. I request him to please rename it so that we know your name.
Yeah. Anyway, good evening, friends. Welcome to this our Saturday PG clinic. I'm extremely sorry for my absence in the last 2 sessions due to academic commitments at other places. Always, I will take care that I should not miss it, because the reason is I'm interested to learn. And unless we participate, naturally we cannot learn. So, Dr. Chinmay, thank you very much. Welcome. And I wish that you can invite other your colleagues to join.
Yes, sir. It is on the.
Okay. Because reason is, that rather than passive listening, if you participate actively on the screen, and that too even put your comments, questions, and we can do even some mistakes, but that's the process for learning from everybody. So I wish that your other friends should also join. And we are fortunate to have the two experts. So definitely their inputs will add to our learning. With this remark, I request Dr. Chinmay to start his presentation. Just for the sake of information to all the friends, we know that here it will be little bit different compared to classroom discussion. Here Dr. Chinmay will share his PPT and initially history part, and then he will share this examination. Gradually we'll discuss that what type of the problem with the child is. Ultimately, probably he must have some very specific investigations revealing the final diagnosis, and probably that's the thing that how we'll gradually start with our thought process and derive the various possibilities in a given case. So Dr. Chinmay, can you start to share your PPT and history part, please?
Thank you very much, sir. Good evening, everyone. Thank you for the privilege. It's an honor to even say a word before you, esteemed faculties. Dr. Rajavati sir has been like a banyan tree. Dr. Yogesh Parekh sir, Dr. Neha ma'am, also my guide, Dr. Professor, and esteemed faculty, Dr. Reddy and Dr. Harimohan. Thank you for lending the ear to me. I would now like to begin with my presentation. So today I am presenting before you a case of a 7-year-old female child who was admitted at our hospital last month, who is a resident of Pandey Sara, Surat, whose informant is her mother. She was developmentally normal, a product of non-consanguineous marriage, belonging to a lower middle socio-economic class, who presented with complaints of cough since 8 days, fever since 5 days, and fast breathing also since 5 days. Key findings were as below. As per the mother, the patient appeared well until 8 days ago when she developed cough. It was in intermittent bouts throughout the day, lasting a few minutes and subside without complete relief with an unknown over-the-counter cough syrup. It is not associated with day or nighttime changes or meals or playing outdoors, or it is or loudness in nature, feeling out of breath or chest pain. The cough disturbs the patient's sleep at night, and there has been 2 such episodes of low volume, non-projectile, non-bilious containing food particles while coughing bouts over this time. The cough has been wet or productive. For the initial 2 to 3 days, it was associated with copious whitish mucoid sputum, which became scant about 1 teaspoon yellowish green after that. The sputum has not been found swelling, frothy, or containing blood. There has not been runny nose, red eye, or skin rash. Third day of the cough, the patient developed fever, which has been high grade, although undocumented by the mother, in nature, with chills, partially with 2 to 3 with about 2 to 3 fever episodes, not changing in frequency or grade, and it happens each day since last 5 days. It has only been partially relieved with over-the-counter medicines. There has not been a day since which was without fever. Also, the patient has been looking ill between 2 episodes and also, since the third day of cough, the patient was noticed to have faster breathing pattern, which was intermittent in nature throughout the day. The episodes are of sudden onset, lasting a few minutes and aggravating on trying to lie down on the right side of the body, and less marked when trying to lie down towards the left side and also while sitting upright. These are not associated with flaring of nostrils, any spaces appearing between the ribs in the rib cage, feeling out of breath, chest pain, blowing of fingers or lips, dizziness, or fainting episodes. On 5th day of fever, the patient was taken to a private general practitioner nearby who prescribed her ofloxacin and gave one sitting of nebulization with budesonide at the clinic. There was no relief of symptoms on oral or inhaled medications. Negative history. There has been no history of...
I think Dr. Chinmay, can you just stop sharing for a while before you provide the more information?
Sure, sir.
Yeah.
Sir, we have many students joined. Dr. Anna is there, Dr. Millie, and Dr. Dhaval.
Okay, fine. Chinmay, not the first slide. Can you just stop sharing?
Oh.
Okay, fine. I think what was my idea, that as you are sitting in the OPD, patient enters your room and mother starts the complaint. And I think our brain should start to think. Initially, we do not know. Here he has given the title with the respiratory system, but not necessarily it can be respiratory system problem. It can be of any system problem, because we know when patient enters, patient does not tell that I am having the respiratory problem. Yes. So the point is that how we are analyzing each information, that's the beauty of the medicine. And I think that's our main aim or goal discuss over here. Ultimately, I think diagnosis can be anything, what even Chinmay may bring out or surprise, something new or totally one which probably we have not discussed. But still, I think our discussion should be relevant. And I think that's the point that every student and every clinician should learn. So with that idea, I think Chinmay has given very good information. He has described the history, chief complaints very appropriately, even in details, with relevant even the adjectives. So I wish that all the students, number one, keep your video on as if we are sitting in the classroom so that we can have the discussion. I think Dr. Dhaval, Dr. Anna, please, Dr. Aarti, even introduce yourself so that we come to know that exactly in which you are and which institution. Dr. Aarti, can you just start your introduction?
Good evening, sir. Myself, Dr. Aarti Solanki. I am third year resident from Sola Civil Hospital, Ahmedabad.
Fine. I think, always the third year resident is the very appropriate person to discuss. Because now know the subject, read so many things. And I think let me start with you, and meanwhile, other your friends will join.
Yes, sir.
What the main chief three complaints he has mentioned, that first the cough, then fever, and the fast breathing. He has provided even the information also of each symptom in detail.
Yes, sir.
From this, what is your likely thought process? That what is the likely problem with the child?
So, sir, the chief complaint was cough, fever, and fast breathing. So that is mostly the respiratory system involved. So it can be due to any infection, or fast breathing can be due to pneumonia. So we'll go in detail for further. Fever, the grading of fever with tachypnea, which has increased in later phase. So
Arti, first always that is the basic place every person should try, that first locate the anatomy, that where's the problem is there. Right, suppose respiratory or CVS, I think after respiratory also try to locate, is it some upper respiratory problem or lower respiratory problem? In lower respiratory problem also try to give these ideas and analysis. Is it airway problem? Is it lung pericardial problem? Is it something is wrong with the pleura? Or really some interstitial issue? So, the involvement of every component presents with a very specific picture. I think that we can try to derive. Even it may be later on change also with some findings and examination. But I think whatever the information we have, we can start it. I think here Arti made very bold statement that it's a respiratory problem. But I will say, why not the cardiovascular? It is possible some congenital heart disease, and that can also present in this way. How will you explain that? Whether do you agree with me? Is it a congenital heart disease or some cardiac problem? Or you don't agree? And I think whatever you are thinking, you'll have to give the reasoning. Arti, can you take it, please?
Yes, sir, definitely it can be some cardiac causes as well. But for cardiac causes, there might be some other symptoms as well, like cyanosis or some cardiac conditions.
Arti, sorry, interrupting you in between, but cyanotic heart disease can present with cyanosis. Acyanotic probably with some severe
Will not
issues will
present.
present. Otherwise, there will be not cyanosis.
They will not present.
So
it. Yes,
cyanosis
sir.
with present, it will help me, but absence does not exclude or rule out. Right?
Definitely, sir. Yes,
Okay.
sir.
So you can take it further. Suppose if you are thinking for cardiac, what of the cardiac problems can present with these type of symptoms? That means where the cough is there, fever is there, and even the fast breathing is there. What type of the cardiac problem? Commonly in the younger children or infants, suppose if you take it. I think here he has mentioned 7 years, maybe too old, but some of the child is 1 year old. And presented.
Yes, sir.
I'm asking for the cardiac problem. Which of the cardiac problems can present in infancy with these symptoms? I think not unusual for you. You must have seen the several patients. And many a times we diagnose as the respiratory problem in the emergency. Because patient present the fever, cough, breathlessness.
We start dilated cardiomyopathy.
Just I'm coming to the point. I will give the hint. And then what happens that we treat the patient. When the acute problem decreases, on auscultation we get, oh, murmur is there, which we missed even initially with this lots many test signs. And then we go for the workup and come to know it is the VSD. It happens, so I will say frequently, it's not an uncommon story. So, most common in short, the shunts are common, usually present in the infancy, right? But if you go in the history will help you. That it was not so that a cough and fever and then fast breathing. Probably fast breathing from the beginning. If you ask the mother, fast breathing has increased on acute presentation, probably with even respiratory insult. But if you ask the mother, yes, fast breathing was there since 6 months, but it was not disturbing. Now it has caused this problem. That means we understand that some shunt or cardiac problem was going on. Now with the respiratory infection, maybe pneumonia or bronchiolitis, it has presented to us with an acute condition. And on the contrary, that type of symptoms are common, right? So here I think the sequence of the symptoms will be different. In cardiac, first this is the fast breathing is going on. Cough may be there. And then with infection, this fever will start. And with that, even the manifestations will be propagated. That of the story is common. Here, cough is first, 8 days. Then develop the fever. And then the fast breathing, right? So Arti, now you can take it. What is the likely problem? Suppose if I say respiratory. Okay, respiratory where? Is it an airway disease? Is it a pneumonia, alveolar problem, or pleura or interstitial? Can you take it?
Sir, it can be due to pleura or mostly lower respiratory tract infections. As after cough and fever, faster breathing has been included. That means accessory muscle use has been there. So lower respiratory tract infection will be more common than airway problems.
Okay. I think
Because
anybody,
the onset is
other students should come to help Aarti. I will appreciate that Aarti is constantly at least responding. That's good. But I think Dr. Anna, can you make your video on?
Sir, if get the video on, mostly my connection will be
no
causing
problem,
issues.
no problem. Okay,
So,
without video you can. What is my? Can you just introduce yourself so that we come to know?
हाँ sir, I'm Dr. Anna Roy. I'm studying in Surat Civil Hospital, third year residence of pediatrics.
Okay, fine. So the question was that how will you try to localize the airway problem, lung pericardial problem, pleura and interstitial? That means what type of the characteristic would be there? Just from the history.
So we can classify from the history, mostly basically based on the symptoms. The upper airway mostly starts with cold, and there is symptoms like stridor, which is specific to upper airway tract, like subglottic and infraglottic and supraglottic. In both cases, we have two types of stridor: inspiratory stridor and expiratory stridor. In supraglottic and infraglottic obstructions and infections, we have, for example, in croup, in epiglottitis. All these cases, stridor is much more common because it is a bigger airway obstruction due to the infection. And
that means Doctor, one by one, I think what she wants to convey that suppose in a case of upper airway problem and there is some obstructive phenomena, some reason, maybe the inflammatory or maybe infective or maybe sometimes some mass compressing or whatever it is. Pathology we do not know. But usually they present with this type of the breathlessness as well as some very specific sounds. And upper airway obstruction commonly they present with the stridor. So I think that's our, always we'll have to have the understanding. And pathology and everything disease we can decide later on because obviously it will not be the clear. Okay, suppose lower airway disease, Dr. Anna, how they present? Airway problem, I'm talking.
We can classify based on fast breathing, nasal flaring, and retractions that the baby presents with. Mother mostly will say there will be fast breathing only. Retractions and nasal flaring and all we will have to see by examination. She might tell you like there are retractions. Gadde padre aise bol sakte hai. Otherwise, we'll have to classify based on fast breathing is a more common thing in a lower airway case, and if the retractions are subcostal and it is more favoring a lower airway, and if it is parenchymal, there is nasal flaring and there is intercostal retraction, which may or may not be told by the mother. We cannot be so sure about that.
Okay.
And
fine. I think one by one we'll take it. The airway characteristically history part, you must be knowing the basics that the airway have the plenty of the cough receptors. And therefore, please remember that the very bad cough indicates usually the airway disease. Classically, remember the bronchial asthma. In bronchial asthma, common presentation is very bad cough. And of course, what Anna said, with this fast breathing and even the indrawings and flaring, it depends upon the severity. All the manifestations may not be present in every patient, but depends. But at least, yes, fast breathing is going to be increased work of breathing, what we say. Increased work of breathing has mainly three components. One component is this tachypnea. Tachypnea is the very fast. Second is always indrawings at various places. And third is the specific sounds. And that will give the idea upon the severity and so. So increase work of breathing. That's the characteristic of particularly the airway. Usually, the lung parenchymal tissues, they are having the problem of cough is not the very prominent feature. But fast breathing, yes. Because some of the alveoli, they are having the compromised lung function. And therefore, the main problem is the fast breathing. Cough is mild. And fever, of course, depends upon the etiology. If it is bacterial, maybe the fever, maybe the prominent. Viral even may not be the fever or mild fever. It depends upon. Pleura, you know that the most commonly it's a mechanical problem. And therefore, mechanical problems, suppose classical example, we can remember the effusion, fluid collection, which is more common. And therefore, how the child presents, particularly presents with this mechanical problem, and therefore the fast breathing, because again, lung tissues are compromised due to this compressive effect. And therefore, yeah, plain may be the initial, even the pleurisy is there. Of course, you are right. That may start with the pain, and then pain disappears with the collection of fluid. And of course, that preferring the side, right or left, you can suspect even in a case of pleurisy. But the usually the indrawing sounds, these are usually not found. But in a case of interstitial disease, you must be knowing it's a very characteristic that they present with more of the hypoxemia. Hypoxemia is very characteristic. If you see that the patient is not that bad, but SpO2 is significantly low. And if you examine the patient, there may be the minimal signs or no signs even. But the hypoxemia is a very prominent. And if it is long-standing, you may get some clubbing also on examination. So I think these are the few points which I wanted to clarify from the history. So I think in this patient, again, if you come back to our patient, what is the likely problem? Chinmay, now you can, if you go for the analysis of this, our patient, the 7-year-old female presented with the, always try to use the adjective. Here it's a 5-7 days. So it's an acute problem. Acute, subacute, chronic, recurrent, episodic. Try to localize, particularly categorize that what type of the problem it is. And that will give you the idea. So I think here it's an acute problem, right?
Yes. Yes,
and main cough and fever and fast breathing, so likely infection. Fever, and again, if you see, he mentioned that the in between even interfebrile period, child remains ill or sick looking. The basics, that means it is likely bacterial infection rather than simply viral. Second thing, he said that the cold is absent. Very nicely, he has described the story. That again does not favor the viral, right? So I think from history part only, we can suspect it's an acute problem. It's a respiratory problem, anatomically lower respiratory problem, likely the lung pericardial problem. And I think severity point of view, we can say that mild to moderate because other features are not there. So I think if you just from the symptoms try to understand, that will give the idea. I think Dr. Raghuvansh, Dr. Reddy, you can take it further. I'm sure that we have tried our best to analyze basics of it.
Please. Very well done, sir. Very well. Thank you, sir. I just want to add,
yes.
Our older teaching what you said, tachypnea. Now that's how the WHO has classified pneumonia. So tachypnea was the most sensitive sign at the centers for diagnosis of pneumonia. So someone having tachypnea, you should think, okay, child has pneumonia. But now when you come to medical college or pediatrician, so tachypnea is not that sensitive. If you see, like a child with a bronchiolitis can also have tachypnea. A child who has a wheezing can also have tachypnea. Aspiration can also present with tachypnea. So tachypnea is not very specific of pneumonia. Tachypnea can, metabolic acidosis can also cause someone to have tachypnea. Someone in early cardiac failure or myocarditis can also have tachypnea. Tachypnea signifies, yes, there is a problem in the respiratory tract, but it is not very classical of defining either as an alveoli, bronchus, or pleura. Even significant pleural effusion can also cause tachypnea. So taking alone a tachypnea may not help us to diagnose, okay, the child has pneumonia. It is one of the signs which can tell you, yes, the child has respiratory tract involvement, and the problem is the child might have hypoxia, but he is compensating by breathing faster to maintain that oxygenation. It means some amount of his parenchyma might have been involved, or the oxygenation is not happening perfectly, so he is breathing faster. Now, depending upon the age, if a child presents with coryza and he's in infancy, then you can think of bronchiolitis may be a more common cause. Or the child presents later in the age group, like after 1 year and 5 years, the fever is more predominant, then you can think of pneumonia And if also with the pain initially and then effusion, then you can think of paranoid incubation with pneumonia. So only tachypnea may not help us to think, okay, the child has pneumonia. It can be sometimes a viral infection. For atypical infection can also cause wheezing for a child, and wheezing itself can cause tachypnea. Some kids can have tachypnea when sick. You may not be audible for it. So tachypnea may not be is a sensitive sign, but not very specific for pneumonia. So it is good to pick up the child has a respiratory problem. Now, what are very specific to pneumonia if you take? So if you see the specificity increases with someone having grunting. When you grunt, when more of the alveoli are involved and child is not able to, the alveoli are collapsing a lot and the child is not able to maintain oxygenation, grunting becomes more significant. Okay, the child might have pneumonia. Or someone has severe subcostal retraction. It means more than 50% of the lungs are closely being involved and the diaphragm is working too much. So probably you may think the child is having pneumonia. But again, bronchiolitis also can have subcostal retraction because of pleural chest wall. Like the chest wall is not that strong in infancy. They can also subcostal retraction. These two are very specific for involving of alveoli. Bronchus, as Sir said, they have more of a cough as a predominant symptom, and they may not have much tachypnea there. So if you see a 7-year-old girl who presents with a lot of cough, but they may not have tachypnea. Their problem is breathing difficulty. They feel just tightness. Okay, so predominant cough, you can think of airway, but again depends upon the age. And predominant tachypnea may not be very specific of pneumonia, but you can think it's a problem with the lower airway tract. And you also have to consider the age, which age the child is presenting with. If it's younger, it can be bronchiolitis. If it's older than that, like 1 year, then probably pneumonia may be a cause for thing. And the rest sir has discussed very well. Thank you, sir.
Thank you very much. I think Dr. Reddy, Dr. Hari, before I come to the point to you, I think he made the very important point, and I'm sure again the students from exam point of view, this point is very, very important. What Dr. Reddy has made, tachypnea. You know, in the medical science, some of the signs and symptoms, they have given the undue or more importance because they have studied it properly, and then they have found out that yes, this is reliable sign, and tachypnea is one of them. Very rightly he said, but you know, he said that it is the more sensitive. That means with the minimal problem or major cases of the pneumonia will be able to pick up if we depend upon the fast breathing for the interpretation. That is the sensitive. But very rightly sir said, it's not very specific because under the umbrella of this fast breathing, so many conditions, even non-respiratory conditions are there. So that's the point I think what he has just thrown the light, that as a clinician we should keep in mind. But the point is, Dr. Arti or Dr. Chinmay, I think you might have read something because you have prepared the case, why the WHO has given more importance to this fast breathing or tachypnea for diagnosis of pneumonia. What Dr. Reddy said as a clinician, I may consider the sensitive but not the specific. But still WHO has given why the undue importance. Sometimes probably I will use even the undue importance, but why it is given? What is the idea?
Yes, sir. So you and Dr. Reddy have rightly pointed out that W has been emphasizing more on tachypnea as a definition for pneumonia. It is rightly so done because WHO not only addresses medical staff or medics, but also addresses paramedics. So at the grassroots level, at community level, at health centers in the periphery, it is more important that the health care worker identifies the symptoms and picks up the particular patient. So I think these three symptoms specifically more so fast breathing and cough and fever are more likely more helpful for the paramedics to help them to identify a patient in need who might or might not have pneumonia or any other airway condition.
Right. Anyway, it indicates that you have the idea. Let me take to the details of understanding. If you see that the under 5 mortality rate of the country like India is quite high, and if you go for analyzing the causes, etiology, factors, you know, the one of the important 3 factors, one is the respiratory, and that is pneumonia. Pneumonia is one of the killer, and that to under 5 mortality is contributed by almost 20% by this pneumonia. And therefore it is decided or by the scientists that now if you bring down this under 5 mortality rate less of the country like India, we have to focus on the respiratory infections. We have to focus on diarrheal disease. We have to focus on the neonatal deaths. And if you could do something, then probably you can bring it down. That is the basic understanding of the science. Then they focus for the pneumonia. Now you know that every patient will not be able to reach to the medical person. Very rightly Chinmay mentioned that, and they actually tested that fast breathing, as Dr. Reddy said, is a very sensitive test. May not be specific, but very sensitive for the pneumonia. Maybe sometimes over it will be done, but it will be good. And therefore it is you know, our medical officers or even the paramedical persons or our ASHA workers, Anganwadi workers, we are training them that fast breathing, and then they have given the cutoff line and gradings also. They are trained like that. That suppose mild, they can treat even without any drug. Even some moderate, then we are given that liberty that even they can start the amoxicillin. You must be knowing the IMCI is a program. And then we understand that it is a really fast breathing. Child is not able to speak, not able to drink. You know, simple sentences, not where the clinician requires. And they understand that, oh, this is severe anemia. And timely reference to the proper place will decrease this mortality in this group. That is the, you know, basic concept of the science. And for that reason, the fast breathing is given the more importance. And sometimes probably with patient which is referred to you, Dr. Chinmay, you have seen that the fast breathing is there, but there is no introing, no any sound. Respiration rate is 80 in a 6 or 8 months old child. What it could be? There is no any respiratory other complaint. Just 80, 90 even the respiration rate, fast breathing. There is no any introing. There is no any sound. Even chest is clear. What it could be?
It could be, there are many possibilities. I would like to begin with the simplest of things. It could be a simple nose block that could present.
In a nose block also, there should be some respiratory symptom or the complaint. You know,
of course, noisy.
What is my idea to, I think simply if I ask Aarti, without any, just simple tachypnea, without other signs of increased work of breathing, which is non-respiratory cause, what it can be. And it's a serious condition. If you die, suppose 7, I would say infants can come with different condition. Even 7-year-old boy is brought to you with very fast breathing, not even the good looking, that is little bit, I will say, serious condition. Sometimes
maybe dehydration, sir.
Dehydration, then what it could be. But that for dehydration, there is no loss, there is no diarrhea.
Yes.
But still dehydration is there and fast breathing is there. And child is sensorially not good. What it could be? I'm sure you must have seen the patient in your ward.
Decay, sir, diabetic ketoacidosis.
Absolutely. And you know, gradually I'm learning, being the teacher, that always make the students to speak. They are knowing, but we have to bring them out. Absolutely. And you know, this is simply, I think, as the patient enters your ward, if you are sitting, as I will say, on call, and if you diagnose even immediately this condition, it's, you know, it's quite rewarding. Your fast breathing is there, but no intravenous. That means metabolic acidosis, what I wanted to convey. And you know, metabolic acidosis in infants, maybe the metabolic that is inborn error of metabolism, maybe the organic acidemia, maybe any something else. So but you know, it sometimes can be the cardiac reason also. And at the same time, this is fast breathing. Child is even severe anemia, not that much cardiac failure. And I measure the blood pressure, it is hypertension. What it can be. And child is not growing properly, failure to thrive. Age-wise, height, weight, everything is less. Parents are not complaining much. But why? And I examine that, even I asked 2-3 times, is it really 5 years, looking 2-3 years old child? And they say yes. And a very fast breathing presented. Anemia is also there, but cause of fast breathing is not anemia, and I measure the blood pressure, it is hypertension. What it could be? Anybody? Chinmay, Aarti. If I give you the hint, it is related to some other system, not respiratory, not cardiac, not metabolic.
Must be renal system involvement.
It's some chronic disorder.
Could be related to kidneys, sir.
Yeah.
Because anemia is present.
It's a chronic renal failure.
Yes.
And all of you must be knowing chronic renal failure, even some of are having, we may not have this understanding, just non-specific symptoms. Child is not growing properly. Anemia, we say it is nutritional, even medical person will sometimes consider like that. And such a patient can present with this acidosis and then fast breathing. And once you measure the blood pressure, probably it will go, oh, it is hypertension. So what was my idea? That Chinmay has given the title respiratory system, but child does not come with the tag of this subsystem. That also sometimes we'll have to define. And I understand, being clinician, it's not so easy even in every patient. Even we are not able to decide the system. Then probably further anatomy is most difficult. So that was my idea. And for that reason, in short, fast breathing is given. Whereas Dr. Reddy said, for the exam, please remember the cutoff value of tachypnea for every age-wise. That less than 2 months, then infancy, more than 5 years and above. And another thing, even in the DM pulmonology, I am learning from my friends. They will ask you that, tell me the respiration rate of your patient. How will you do, Aarti? How will you count the respiration? We are not sitting in the classroom. Otherwise, I will say, demonstrate me.
The whole 1 minute respiratory rate count.
That is very important point. At least count for complete 1 minute. Okay, what else? During counting, what you will keep in mind? The
child should not be disturbed. Child should be in comfortable position, in whichever position child is comfortable.
Okay, right. Let me say, at least not in. Yes, Chinmay?
The child must not be crying.
What precaution you will take as an examiner? Patient point of view, okay, the child should not be crying, child should be calm. If sleeping, probably it is quite helpful to you. Understood. While counting, what Aarti made the statement very important, count for total 1 minute. Respiration rate count at the level of the chest. Keep your eyes at the level. Second thing, inspiration and expiration sometimes will count even both as a 1, a 2. Actually, it is 1, the respiration rate. So I think these are the simple, very basic things. But the most teachers and even in advanced technology, if you start from these basics which are understanding and then go for the advanced technology, probably nobody can teach you. So this was just my point to sensitize you. I think Dr. Hari, you can take it further. Whatever we are missing, please, you can add it.
Please, sir. And thank you, Academy of Gujarat, Paediatrics, Gujarat Academy and Seni Group program for inviting me to such a wonderful program. And thank you so much, sir, for taking it forward in a very elaboratively and excellent manner. As we have been discussed, this is the case of respiratory system or else. So whenever we are dealing any patient in the OPD in emergency setting, it is very important to understand which system is affected. It is the unisystem disease or one system disease, or it is multi-system disease. Number one, it is very important because sometimes you can get the respiratory system with other systems affected also. Like as the sir rightly said, so there are two kinds of the causes of tachypneas. Broadly, we can classify it in the 2 groups, whether it is pulmonary or extrapulmonary. So first, whenever you find the tachypneas or any kind of symptoms, those are pertinent to respiratory symptoms. Please understand whether these are pertinent to respiratory system or extrapulmonary system, or it is one system is affected or multi-system is affected. Second is very important. When you can find that it is only the respiratory system is affected, please elaborate the severity of disease. Sometimes it can be mild, it can be severe so enough, because sometimes it is so severe, it does not give enough time to evaluate and does not give time to treat. So whenever you find the severe state of disease, like in case of severe pneumonia, rather you are wasting the time to taking the detailed history and do the examination. You first act to manage the child. Otherwise, sometimes you are wasting your time. Child is so hypoxic, sometimes going in the gasping state. So try to understand the severity of disease and try to do the trials and manage accordingly on the depending on the severity of disease. Suppose a child is not so sick, you can take your enough time to take the detailed history and do the examination. If child is so sick, then do the brief history and act promptly so that you can save the child, and devote your time to take the detailed history on the follow, and then after stabilizing the patient. That is very important.
I think Dr. Hari has taken the very important point. Anyway, as a teacher, I am learning that if the multiple teachers are there, all of us are learning from each other. And students are probably at the maximum benefit. What sir made the point that, you know, so it depends on, as a clinician, we'll have to learn all the things. Very important, what sir said. That I am person like me will be insisting on history taking and then go for the drugs or medicine or something. But you know, it depends. As I was talking that suppose the child, if you are suspect diabetic ketoacidosis, you cannot sit and take the history in details and then start the treatment. I think it's a part of training in the intensive care or the how you should manage such patients. You know, here all the things should be going on simultaneously. You are asking some part of the history or information. You quickly examine the present status of the patient. Even you collect the samples for some specific investigations before starting the treatment. So your investigations are not getting the altered results. And at the same time, quickly, whatever is required or life-saving should be started immediately. So I think that point is also, sir has said, very important. That depends upon the severity of the condition when the patient presented to you. Suppose if it does not give the time, then probably you will have to act very fast. And everything should be simultaneously together. So for diabetic ketoacidosis, you can ask the sister to go for the sugar. Immediately you get the idea, get the IV line, collect some samples, and meanwhile start the fluid, because dehydration is the major killer. The sugar is not the major killer in diabetic ketoacidosis. I think that I should know. And if you just even correct this dehydration, patient can be saved. And later on, you can go for further workup. So I think Dr. Hari has also pointed out a very important point, that see that at the presentation, what is the severity of the disorder, whatever it is, and accordingly you act very fast. And suppose patient is just stable and has come in the OPD, of course you can go in the details and then you can decide your action. So I think that point is also quite valid. Thank you very much, sir. I think we have taken sufficient time in understanding the basic symptoms. Now I think Chinmay, you can finish our history, then again we'll go back for the discussion. I think
Sure,
if anybody wants to add something, yes, sir, or we should go for further.
Yes, we can go ahead, sir.
Okay, Chinmay, go ahead.
Yes, sir. I would like to continue with the negative history. So there has been no history of red eye, runny nose, snuffling, redness or itching of skin. There has been no history of loud barking sounds, noisy or labored breathing. There has been no history of nighttime or early morning coughing bouts, feeling out of breath or pressure over chest, blowing of lips, fingers and toes, skin allergies, recent exposure to smoke or fumes, or repeated use of nebulizers. There has been no history of blood in sputum, night sweats, unplanned loss of weight over past 6 months, or exposure to contacts with a diagnosed Cox disease patient. There has been no history of feeling breathless while trying to lie down from sitting position, or getting up from a lying down position, or sleeping or sweeping of both legs by evening. There has been no history of foul-smelling, yellow, purulent, blood-tinged sputum. There has been no history of pinkish, mucoid, frothy, or flaky sputum. There has been no history of earache, ear discharge, hard earwax, giddiness, hearing changes, or pain behind the ears. There has been no history of soreness of throat, painful swallowing, or voice changes. There has been no history of blocked nose, allergies, mask coming out from nose, or repeated sneezing. There has also been no history of heartburn after or before meals, cough while lying down after meals, recent appetite or diet changes. There has been no history of swelling or puffiness of legs, cough while walking, playing or doing household chores, racing of heart, dizziness, sweating of palms, or loss of consciousness. There has also been no history of increased hunger, thirst, or urinary habit changes, unplanned weight loss, use of blood sugar lowering medications. There has been no history of foreign body insertion or aspiration. There has been no history of use of any medications for lowering blood pressure other than OTC medications prescribed recently, which were antibiotics and ambulance drugs in the past week.
I think for a while, just Chinmay, will have to stop the sharing because it is very important, relevant to your exam also. I think you have elaborated and covered many points for the negative history, very long list. And same thing happens in the exams. But you know, what negative history will include? Not standard given in the textbooks for including all the conditions. You know, naturally, I'm sure that 7 years old child, there is no need to ask for the foreign body. That is not the age for the foreign body, right? Second thing, you know that the what type of the negative history you should. Negative history should be short and sweet and related to problem of your patient. Of course, all the points which you describe should be there in your mind as a knowledge, but then you should apply according to your patient. Suppose here, if you are thinking for the pneumonia, then try to derive, is it really pneumonia or something else? And related to that negative point, very near negative points, you should mention so that either it strengthens your possibility or exclude the net differential. That should be your idea. Second, as I said, you know, nearby differential point should be there. And third, some expected complications or severity of the disease. Suppose here, if you are thinking for the pneumonia, is it really some necrotizing pneumonia? Is it really developing some lung abscess? Is it really some developing empyema? That means these are the known complications or severity of pneumonia. And related to that point, you may try to derive in the negative history. So I think all the students, please remember, you know, at the most, okay, you can ask that the repeated history of cough or breathlessness in the past, that one sentence is sufficient. That means you are excluding the episodic or recurrent problems. That's all, right? That means it's not the recurrent. It's not asthma, right? Or something hyperreactive airway disease. That is very easily from one sentence you can rule it out. So like that you can mention. But I think regarding this sputum, which is indicating just congestive cardiac failure and pulmonary edema, I think may not be relevant to my patient. So the point is, again, if I mention, you know, in the history, there is a 30 minutes in the long case to assess. In 30 minutes, you have to show your ability. And therefore, go there with presence of mind. And very, you know, that's why I remember Dr. Ambedkar sir's comment that what should be the response of the student? A, B, C. Very accurate. Very accurate. Don't give the opportunity to the examiner for the next question. You should be so accurate. And second, brief. You know, as a postgraduate, undergraduate student can give the history differently. The child had the problem, shown to the general practitioner, then went to the taluka place, and then came to me. I think, you know, that story is not expected from the postgraduate. Because undergraduate, okay. So that brief you want. And so ABC and clarity. Whenever you are presenting, you know, your I will say narration should be focused. That on which point you are trying to focus. Many times the examiner need not to ask the question, from your, I would say, description, it becomes very clear that what you want to convey. I think that is very important for all the DNB or MD examination. That go with that preparations in your mind, right? Related to negative history, simply 2 or 3 points related to my case. That's all. Of course, if the examiner asks me, you can answer everything. You have to answer. But otherwise, in your narration or description, it should be very short and sweet so that you can save the time, you can provide the information, can get the more time for the discussion, and can reach even to the further discussion with the advancement. Right. So I think this is very, very important. Am I right, Dr. Reddy?
Yes, sir. You're absolutely right, sir. Like if I'm young, so I would have given my exams 10 years back. But if I think you're all going for exam. I tell you, in the stress of what you're given an exam, if you see it an exam point of view, taking that history, writing down, and presenting 3 complex things, and bringing all your 3 years knowledge into that point of a time is a big challenge. Okay, unless you train your brain to take a history, only short negative history, which is very relevant, and then you don't get time to write a paper also. Everything is written in your brain. And when you're presenting to the examiner, looking into his eyes, confidence what you speak, that is more important. You can't look at your case sheet also. And believe me, you'll not be looking at your case sheet. Okay, you start with the first complete name. After that, you will keep on going on. Just what you remember, you'll be speaking, but you can't see your case sheet again because the examiner will be stopping you, asking you questions. I believe you will not see your questions like what you've written. You only see your name and age and those things. And after that, you will not see your paper at all. So everything is in your brain. Try to present without seeing a case sheet. If you can do in this 1 year for 30 students, then I think your exam will be easy for you. But you can't see your case sheet at all. That's what my experience is.
Yeah,
Sir,
absolutely.
Many students, sir knows better.
I think to the students, this is just to boost up, right? Always everybody has passed through the same channel. So don't get, I would say, discouraged. Every person, every professor has done the same channel, same problem, same mistakes. But as the time passes, gradually all of us are learning. But we wish that you start from learning from the very beginning, so that probably your performance can be better. I understand. And I'm sure that for that reason, always try to all these things implement in your daily rounds. As far as possible, give these rounds without the use of the case paper, because you know your patient. And in a round also, you know that what is the important point to be mentioned in this patient. So, and once you go, ultimately we have to train ourselves. And once you are trained, probably you can do in the exam in a better way. Many times a teacher like me, I will say that I have to see even how the person is walking. From the gate, I can understand whether he has worked in the ward or not. Naturally, because there's, as Dr. Reddy said, your body language, your confidence, your response to the question, how you are answering, that we have seen the patient, all the things probably he has not to ask the Nelson. Ultimately, examiner has to see whether you are really appropriate to be the good clinician. And later on, you are going to develop very fast. What we took 40 years, probably you will be able to do in a very short time. But for that reason, I think this is very, very important. So I thought that, this is not just a case discussion as we do for the practitioners. This is for the postgraduate, and we want to prepare you even for the best performance in the exam. This is our idea. I'm sure that you will take in a proper perspective. Right. Thank you very much. Dr. Hari, you want to add something, or should we go further? Dr. Hari, you are not audible.
Sir, let us go further, because Dr. Hari has some audio problems.
But I think others are all, even I was thinking for my date, but I thought that it's all right. Okay, Chinmay, you can go further. Dr. Yogesh rightly said.
Yes, sir. So I would like to continue with the rest.
Yes. I think I take it further from the negative history.
Okay, sir. Next, the personal history. The patient.
Chinmay, your slides are not seen. Chinmay, your slides are not seen. Yeah, now you are sharing. It is seen.
Okay, sir.
Okay, now slide has come. Yes, now it has come. Please go ahead.
So, sir, this I would like to continue with the rest of my history. Coming to the personal history, the patient studies in second grade of primary school and has average scholastic performance as per her mother and school teachers. The patient follows a lacto-vegetarian diet. The patient has been not on any medications recently, except tablet ofloxacin for the past 3 days before the hospital admission. In the past history, there has not been a history of similar episode in the past. No history of repeated use of nebulizers, blood transfusions, clinical visits, or hospital admissions. There is no history of bronchiolitis, Cox disease, bronchial asthma, any known allergies, influenza, measles, congenital heart conditions, or cardiac procedures. There is no history of proven COVID-19 infection in the past. There is no history of any vaccines received over and above the universal immunization schedule. Family history, there is no history of similar episodes in the family. The father has been an active smoker since past 10 years and who also smokes indoors regularly. There is no history of Cox disease, bronchial asthma, proven COVID-19, influenza, measles in parents or siblings. Birth history. My patient is the fourth in line of the non-consanguineous couple. My patient was born full-term normal vaginal delivery with birth weight of 2.1 kg at government hospital in Bihar. She cried immediately at birth, and there has been no history of NICU admission. There is no use of invasive airway procedures or use of mechanical ventilation. The date of birth is 6th of October 2015. Patient received birth vaccines on day of life 1. The patient was being fed the mother's breast feed along with diluted cow's milk on and off. Complementary feeds were started at 5 months of age and was weaned off completely from the breast milk by about 20 months of age. Immunization history. BCG scar present over left deltoid region. Immunization record documented in the Mamta card. WHO universal immunization schedule was followed. Vaccination received up to 5 years of age complete. Next vaccine schedule of DPT2 awaited at 10 years of age. There were no documented adverse events following immunization. Developmental history. Age appropriate fine motor, gross motor, language and social milestones achieved timely upon interviewing the mother. Diet history. Patient is following a lacto-vegetarian diet. With respect to the age appropriate daily energy and protein requirements, there is 16.8% calorie deficit and there is 7.6% protein deficit in the daily diet. Socioeconomic and environmental history. The patient's family lives in an industrial locality with a major road with heavy traffic adjoining the house and a chemical factory located within 200-meter range of the house. The house is pakka and has 2 rooms without any attached toilet. The patient's family comprises of 6 members living in the house. The source of potable water is the unfiltered tap water supplied by the Surat Municipal Corporation and also borewell. Common toilet shared by 2 other neighbor families is being used. Food is cooked on a smokeless stove in the house and the house has 1 door and 1 window. Summary. Done with the history.
Okay, I think you can finish it because we have to keep in mind the timing also.
Okay, sir. Summary. I would like to summarize the clinical history. This is a case of a 7-year-old female child who is a resident of Pandesara, Surat, whose informant is her mother, developmentally normal, product of non-consanguineous marriage, belonging to a lower middle socio-economic class, who presented with complaints of cough, fever, and fast breathing. The cough is since past 8 days is wet with scant yellow-green mucous sputum, intermittent bouts throughout the day without complete relief on oral medication with 2 post-recessive episodes of vomiting. Also, 2 to 3 daily high-grade fever episodes with chills since 5 days, accompanied for the same period with sudden onset fast breathing episodes aggravated on lying down on the right side of the body and less marked when trying to lie down towards the left side of the body and while sitting upright. No improvement on ofloxacin and budesonide. There has also been history of top feeding, early weaning, early discontinuing of breast milk with poor daily nutrition and an active smoker in an overcrowded house of air pollution with poor sanitation and potable water supply.
Yes, go ahead.
Next, anthropometry. The patient weighted 17.2 kg, which is 78% of the expected. Her height was 114 centimeter, which was 95% of expected, and her body mass index was 13.23 gram per meter square. I have also demonstrated the growth chart here. Her weight for age and height for age, both were below 25th percentile. General examination, sir.
Yes. I think you can complete your examination, then we'll go for the discussion so that we can save the time.
Okay, sir. I have examined the child with verbal consent of mother in presence of a female nurse in good daylight and exposures. The child is alert, conscious, cooperative, oriented to time, place, and person, and not in distress. The temperature on admission was 101.1 degree Fahrenheit. Pulse was 100 per minute in the right radial artery. It was well palpable with increased volume. The respiratory rate was 28 per minute, regular, thoracic, and non-labored. BP was 110 by 76 millimeter of mercury, which is 95th percentile as per age. SpO2 was 99% on room air in right index finger. RBS was 92 milligram per deciliter. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, icterus, or subjective pain. General examination, continuing that towards head to toe exam. The head had normal contour, symmetrical, non-tender on palpation. Face and eyes showed no abnormalities. Ears were bilateral, external auditory canals show no discharge, bleeding, or earwax. Both pinna are non-tender to pull, no signs of inflammation seen. Bilateral mastoid region were non-tender, no sinuses or abscess were seen. Nose bilateral nerves show no serous or mucoid discharge, no bleeding, polyps, or inflamed mucosa. Turbinates appear normal and there was no nasal flare. Mouth and throat, good dentition as per age with deciduous upper jaw incisors missing. Buccal mucosa, tonsils, uvula, tonsillar arches, oropharynx appear normal. No signs of inflammation and no halitosis. Neck appear normal with full range of motion. No engorged veins and no sternocleidomastoid muscles. Finger and toenails appear normal. Skin appear normal without scars or pigmentation, and there was no palmar erythema. Abdomen is soft, non-tender, with no enlarged liver or spleen. No masses was palpated. No guarding or rigidity was seen. Upper and lower limbs show good tone, full power, and full range of motion at joints. Back and spine appear normal, no abnormal curvatures or defects. External genitalia upper prepubertal and normal. There was no signs of dehydration. After the fever subsided, I examined the patient again. It shows that the child was alert, conscious, cooperative, oriented to time, place, and person, and not in distress. The fever had subsided. This is my typing mistake, I'm sorry. The pulse was 90 per minute in right radial artery, well palpable, and now the volume has decreased from increased to good volume. The respiratory rate was 22 per minute, regular, thoracic, and non-labored. BP was 96 by 60 millimeter of mercury, which was 50th percentile as per age and height. SpO2 was 99% on room air. I would like to proceed with the systemic examination. I would like to focus on the examination of the respiratory system door particularly. As per the clinical history, I have examined the patient in good daylight with exposure from head to waist in sitting and decubitus positions. On inspection, the breathing was regular, thoracic in nature. There was no nasal flare, no grunting or no audible stridor. The accessory muscles were relaxed. Symmetrical chest with chest wall without any chest wall deformities. No flattening of intercostal spaces noted over chest during inspiration and expiration. The back of chest appears normal with normal spine curvature, and both shoulders are at equal level with symmetrical movements. There were no engorged veins, no scars, sinuses over the chest. Nipples are at equal level. Breast buds are not appreciated. No supra or infraclavicular fullness was noted. On palpation, the trachea was positioned in the center. There is symmetrical on inspiration and expiration movements with no chest tenderness and no palpable crepitus. Vocal fremitus was increased over the right side of mid-axillary line below the level of nipple as compared to the left side. Percussion, upon percussion, the notes were resonant, heard bilaterally in mid-clavicular, mid-axillary, and scapular lines, except in the infra-axillary region on the right side, which demonstrates non-shifting dullness as compared to the right axillary and left infra-axillary region. Area of cardiac dullness was normal. There was no change noted in the percussion note in changing positions to left and right lateral decubitus positions. Upon auscultation, normal resonant vesicular breath sounds heard bilaterally at all area except right infra-axillary region, where breath sounds were absent as compared to the right axilla and left infra-axillary region. Also, increased vocal resonance heard distinctly over right infra-axillary region. No egophony noted. Fine crackles are heard over the same region as compared to the left infra-axillary region. There were no rubs, beats, or stridors heard. No change in note on changing to right and left lateral decubitus positions. Summary, I would like to summarize the examination finding and history. Upon general and systemic examination, this patient has a right infra-axillary region demonstrating dullness on percussion with increased tactile vocal fremitus, absent breath sounds, fine crackles, increased vocal resonance, but without localized indrawing or without tracheal deviation. Now, shall I proceed with the case summary?
Yes, yes, summary.
Based upon my clinical history and physical examination, I am of the opinion that this could be a case of either typical infective primary community acquired right lobar or lobular pneumonia. My second differential is bronchial asthma with localized atelectasis. My third differential is pneumonia with localized parapneumonic effusion. And my fourth differential is a lung abscess. Management.
Okay, I think that part you can stop sharing now. Okay. Let us see on the examination. I think I request to experts to take this examination part. Dr. Hari, can you start it? That whatever he has mentioned, the examination findings, you can take it for further discussion.
Yes, sir. Actually, he did a good job in the examination part, but whenever we are doing the examination, there are certain things must be keep in the mind. First, the documentation of the all things in a systemic manner, as you did rightly, and try to initiate the observation findings, and we must focus on the whatever the pertinent to the disease. If your case is the respiratory system, first you have to localize the which part of the respiratory system is affected. So after the examination part, which part of the respiratory system is affected according to Dr. Desai?
Sir, lower respiratory tract is affected.
It means it is the airway disease or parenchymal disease or interstitial disease. Which part?
Sir,
predominantly airway disease.
Sir, the lung
Yes.
parenchyma.
Once you focus the parenchyma, so one outcome of your examination is predominantly the lung parenchymal disease. Once you find the parenchymal disease, you must localize. You must understand what is the focal involvement or is the generalized involvement. It means the single segment affected or multiple lobes are affected. It is the unilateral disease or bilateral disease, along with or without the airway involvement disease. So first you should start from the upper airway to lower airways, lung parenchymas, then chest and pleura. Do the examination in the systemic manner along with the keeping in the mind in the your disease, suspected disease patterns. So you mentioned everything in the examination, but examination find which must be pertinent. So what are the pertinent things in the upper airways in your case? Those must be looked out.
Sir, in the upper airway, there was nothing.
So whenever we are suspecting disease that seems to be infectious disease, we must understand whether it is likely the bacterial disease, likely viral disease, or something else. So try to find out the clues to correlate the, because right now we are more likely to establish this is the lung parenchymal disease. Now we should focus on the etiological part. So whenever doing the examination, you must focus on the all examination pointer. Those can contribute to the deciding the etiologies. So what we are looking for in the upper airways? It seems to be bacterial disease or viral disease.
Sir, it seems more likely this disease could be of bacterial origin.
So whether it is the viral or bacterial disease, it comes to after the detailed history as you take the certain points in the history and do the examination. Because in your history or symptoms are only fever, fast breathing and cough. So whether it is the viral disease, seems to be a viral prodrome. Those usually upper airways are affected. There are runny viral discharge, runny watery discharge, ocular involvements, pharyngitis, tonsillitis, otitis media. So you keep in the mind in the examination system. There is no need of the detail. Everything is written in the examination system in the inspection as well. So in this case, whether his child is sinusitis, whether his child is otitis media, there is any inflammation in the tympanic membrane, there is a fullness of the tympanic membrane, there is whether the watery discharge or the purulent discharge in the nose, there is a unilateral nose involvement, violent nose involvement, is there evidence of the pharyngeal inflammation or tonsillar enlargement, there are pustular findings, pustular pharyngitis. Sometimes these examination should be pertinent as we go in the lower down in the chest examinations. There's also see the whether the findings, whatever we have taken in the history, those must be correlate in the examinations. Whether that, as you said in the history, there is the fast breathing. So you have to make confirm that really the child is a fast breathing, or what is the appearance of the child, whether it is the sick child, or whether it is the well child, whether it is the unconscious child. As the sir rightly said, we are now right now we have to differentiate whether their cause is pulmonary, extrapulmonary. So keep in all those things in the mind. Keep in the observational find whether tachypnea, as the mother said, is rightly corroborating. Then come to on the retractions part. Retraction is which part is more involved, whether the intercostal retractions are more, suprastitial retractions are more, whether those are associated with the nasal flaring or not, because such kind of retractions or nasal flaring dictate the severity of the disease. If only the suprastitial retraction, there can be only upper airway involvement. There, as the Dr. Aarti rightly said, pointed out, There is the intercostals and the subcostal retraction. There is the predominantly disease of the lung parenchymal involvement or interstitial involvement. So try to find out the retraction along with the tachypnea. Then see the all whether the movements of the chest, whether those are symmetrical or unsymmetrical. Those also shows that there are unilateral involvement or bilateral involvement. Then also come to on the fullness of the intercostal spaces. That is very important. So chest movements is very important, and see the location of the tracheas, whether it is central or displaced. As you have
Okay, I think there is some net issue with Dr. Hari. I think Aarti he has mentioned that the respiration rate was 28 with 101 degree fever. And that respiration rate is 22 when the child was afebrile. Is it tachycardia for 7 years old child?
Sorry, sir.
In other way, what is this cutoff value of the tachycardia for 7 years old child?
More than 100 will be the cutoff for tachycardia.
No, I'm asking for tachypnea, not tachycardia. Tachypnea. What is the respiration rate cutoff value for 7 years old child from where you will consider that this is tachypnea? Chinmay?
So as far as I know, it could be 24 per minute for a 7-year-old female. 24 per minute.
What is for the more than 5 years? What is the cutoff value for more than 5 years?
More than 30.
40.
Okay, easy. You know, that's why I'm asking that the people will start from the basic questions. And now if for the 7 years old boy, if you say without fever, 22 respiration rate, whether does it fall in the definition of tachypnea? Yes or no? Answer me simply. Aarti says no. Then Chinmay, what you said, what we discussed as the fast breathing diagnosis of pneumonia. Now, so this patient has no pneumonia to me. Because what we discussed so much, very sensitive, I would say marker, that marker is absent in my patient. So I will say where is pneumonia? There is no pneumonia. Because tachypnea itself, what we discussed so much, is absent in your patient. Now, what is your explanation? I think number one, do you agree with me that cutoff value for the tachypnea, what WHO has given the guideline, that if we try to follow, our patient does not fall in the category of tachypnea. I think you should agree with me, right?
Yes. Yes, sir.
Now the next point, what we discussed so much, that tachypnea is a very sensitive marker for diagnosis of pneumonia. Very sensitive marker itself is absent in your case. Then I will say where is pneumonia? How will you explain? And these are your findings, right? Which I was not aware, already you have told, I have noted. Then how will you say they still justify the pneumonia?
Yes, sir, it is correct. It is, as you mentioned, tachypnea at the point of time, even when the patient presented to me at the time of admission, when the patient had fever and after the fever subsided, both the values of respiratory rate were below the cutoff range of 30. So, but again, the mother has been giving the history that she has intermittent bouts. It is not that the fast breathing is throughout the day. Maybe it could be that the patient may not have presented at that point of time with that particular.
Chinmay, my next question. Which type of pneumonia will present with intermittent tachypnea? Because you said that sometimes it may be tachypnea, at some other time there is no tachypnea. Am I right? That is your interpretation. That mother said it was there, but when you examined it was not there. And therefore you said that even your history also mentioned that there was the intermittent tachypnea. Then can you meet this type of the pneumonia which will present with the intermittent tachypnea? That means at some other time there is a fast breathing. At some other time it totally goes to the normal, and still by diagnosis is pneumonia. How will you justify? What is your explanation?
So also there's it is there in the history that there is a specific complaint that if the patient is lying down, decubitus lateral position on the right side, it aggravates, and it is markedly reduced when the patient is on a sitting position and left cubitus. So
I think and that's why I'm telling the students, examiner has never decided the questions. Questions are given by the students. And when the student is giving some comment or explanation, should remember that what will be the next question. And you should be prepared that whether you are able to answer the next question or not. Otherwise, put the smartly this comment, right? Because now what you have come, that a child is getting the more breathless, particularly in the lying down position on right side, is it?
yes.
Then what is the mechanism? Why it happens so?
Yes.
Or in other way, first understand the basic principles of science or respiratory examination. In which condition child will be comfortable, which type of the respiratory problem, where the pathology is on the same side. And in other way, other patient will get this relief when they're lying down in the opposite side or opposite position. Can you give this example?
Yes, sir.
Arti or Chinmay or anybody?
Sir, in case of pleural effusion, if there is pleural effusion on right side, child will lie on right side, child will be more comfortable.
Yeah.
But in cases
why
of
Arti? Arti, you give the explanation also. Why? Suppose to make it simple to understand, pathology is on right side, and that you said pleuris is there, and therefore what Arti said, that if the child is lying down on the right side, getting some relief from the pain. Am I right?
Yes, sir.
Why it happens so? Why the child is getting relief? Chinmay, very simple.
Yes, sir. It is based on the respiratory physiology that even while in sitting position, there happens to be that the upper lobes are more ventilated compared to the lower zones of the lung.
Always in the exam, answer simply. Right? Don't make it complicated, because we are inviting the trouble. I think here the problem is very simple. when you are lying down on that side, right side, what happens to the movement?
Decrease.
Movement is
restricted. Yes.
Movement is restricted. Movement will be decreased with the respiration. And that naturally in the pleurisy, with the decreased movement, there will be less rubbing, lesser the pain. Very simple. One of my friends, I remember, physician, he used to say that as such in medical science, there is more of the common sense rather than the extra skill. And I think here we understand that with this position, lesser the movement, it gives a relief. Now the Arti, but in which condition? On that side of pathology, if it's lying down, the problem increases. That means more pain or more problem.
Consolidation or collapse, sir?
Why consolidation collapse? Consolidation collapse, are you getting the pain?
No, sir, no.
Then here the pain is there. So what is another my point? Try to understand the medicine. And even in patient or practice also, that application works very well. Really, CT scan may be normal or confusing many a times rather than giving the guiding me. But your clinical understanding and interpretation will, and that you can explain that why when the CT scan is showing this much or some different point. Very simple. Suppose in a patient of rib fracture, if the person is lying down the same side, more pain, right? So always try to understand. But I think respiration point of view, Chinmay, we are making it more complicated. Keep it simple, right? I am sure another thing, nowadays in pulmonary examination and even in cardiovascular, I think 7 years is little bit older child, but younger the child, suppose infant, and with that small chest, and different anatomical lobes and pathology at very small place, I think very difficult for any clinician to find out all the signs and symptoms. We cannot, practically we cannot. And therefore do not go for the manipulation even in the exam. Examiner also understands. It's not possible. The point is, and on the contrary, such a small lesion will be overlapped by some other normal tissues. And therefore, in spite of the pathology not allowing to give the signs on examination, it happens so. And therefore, now the percussion, in particularly cardiovascular system, has given the lesser the importance. Or some people say even use the obsolete. I will not go to that extent. But the reason is probably does not contribute much in your clinical interpretation. That's actually in nutshell. So always try to find out. Now, coming back, normal respiration, if your diagnosis, then you will have to ask the pulmonologist that what type of the pneumonia I'm getting. My diagnosis is pneumonia. The respiration rate is normal. Dr. Reddy, I think you can just explain this point to us, please.
Under the question, he says intermittent tachypnea, what the mother was saying. So she's not lying, actually, she's true. Whenever the child has fever, the heart rate and respiratory rate actually both increase. That is what she's saying. She's not saying anything else. It's just
absolutely.
So she's saying that the intermittent tachypnea is explained only by fever, but not anything else. And she may not be that knowledgeable to diagnose a tachypnea in another child. Obviously, when someone has fever, that is what the main complaint. If you see practicing pediatrician, the child is breathing faster. And when you examine the child in a calm position, they're not in tachypnea, but when the child has fever, probably tachypnea will be there. And that is very common. Now coming to...
Sorry, Dr. Lee, to interrupt you. Really sorry. But to give the understanding of this point which sir has brought out. Many a times it happens in my round, as you say. Resident has write down the note, what the mother has said. And what sir said, absolute in any condition. The fever respiration rate is, even pulse rate is high. And when the patient is calmed down, all the findings will totally change. And then I will ask the resident, both the findings are of yours. Then you justify. Or on the contrary, what you should ask the mother, that what you are telling that the fast breathing, is it associated with the fever or without fever? Then I'm sure that mother will come, oh sir, it is with the fever. Whenever the fever is there, child is having this fast breathing. And when the fever comes down, he's comfortable. That what is my point? In a history, these points the clinician will have to find out, because mother does not know the importance of this point. But that will give me the lots of the ideas. How much importance should I give? That's really beauty of the history. I think Dr. Reddy has brought a very important point. Even he thought, I was thinking the same, that it is not asthma, right? It is not some other condition. I think in pneumonia, it will not happen so. If it is really mild, even the pneumonia, very small pneumonia, without much finding, not necessarily the tachypnea can be there. Tachypnea, when it happens, when the significant of the lung parenchymal tissues are already becomes non-functioning. And as very specifically, when and then ultimately oxygen supply should be as per the requirement of the body. So now what happens? Body is breathing for more times. Very simple. Why the tachycardia in a case of cardiac failure? Because with each contraction, what we say the stroke volume decreases, but the requirement cardiac output has to be maintained. So heart has to breathe very fast. So number increases. Here respiration tachypnea is also due to the same thing. But suppose some patch or small pneumonia may be having some symptoms, or you may get some signs, but may not be, and therefore beyond tachypnea or increased work of breathing, indrawings and sounds and everything may not, it depends upon the increased work of breathing or severity. Dr. Reddy, you can take it further, I think. Very, very good point, sir. Please.
Next to the question of why the child might not have tachypnea, the child came to you. So when the doctor asks you, examiner asks you, probably you should give a reasonable answer, which is satisfying. Sir, the complaint was tachypnea, but the child had received an antibiotic outside, a treatment, which probably would have helped the child to reduce some of the symptoms. Then it will save you. But if the same thing question comes, then there's no other answer you can explain why the lesion may be less and child has received some treatment which has probably the child has responded to it partially. That is maybe one explanation which I have. If it's the pneumonia case, that's the only explanation which I have as of now.
Yeah, I think absolutely palatable, swallowable answer. And what sir said in the exam also, try to find out that the child has come to me after 5 or 7 days or whatever the days and given some antibiotic. And that's why probably it is partial treated. And on the contrary, any condition in the medicine, when present with some partial treated, classical findings are not there. And that is the greatest challenge to the clinician to decide. Then now further how you should take it. But as he said that really if you consider all, and that's why the history, why the examiner, or I will say you should go the details of the treatment received. Treatment received can totally change the picture. And then you should not be misguided. My even following interpretation of my investigations also be with a reference to the antibiotics or treatment given. Because we know that it can change. Suppose my blood culture for the enteric is negative, but classical picture of enteric, it is enteric only. Blood culture, because I have taken the blood culture after 5-7 days of the antibiotics. So I think, and as he said, if you give this as the explanation, then definitely it will be accepted. That the child may be initially the tachypneic, but I am not, and therefore, next question sometimes what the examiner will ask, after how many days of the admission if you examine? In your ward also it may happen so, that examine 3 days back, today you have prepared the case. And therefore probably on that day's findings and today's finding will be getting changed. And still suppose that, diagnosis is pneumonia, then you can say. So similarly, it happens even a pleural tapping. There are findings will be there, but already somebody had tapped the fluid. And after the tapping was the patient in the exam, the signs and symptoms even will be changed. So the point is, I think that is, everything with the reference to this clinical picture we have to consider. It happens so. I think one point you mentioned, very important point I will appreciate, always in a case of pulmonary case, otherwise also, history of smoking in the family is very important. And particularly in a hyperreactive airway disease or asthma. When you are following any child of asthma, in spite of your proper explanation of, I will say, and using even the bronchodilators appropriately with the use of the inhalers, and even the spacer, still the parents come back to you, there is no response. Always ask the history of smoking. Several times it is the history which is not allowing the child to improve. I think this is very important point which you mentioned. I think another thing you mentioned, the shoulders level. Arti, what is the importance of shoulders level in the case of respiratory cause? That means suppose both the shoulders are at same level or some displacement, or both are elevated, both are down. Can it happen? And if it is so, really in which conditions? Any idea? Any idea? I think other students are there. I'm not sure because the Dr. Dhawan. Chinmay, you have mentioned, so you must have the idea because you have mentioned in your history the examination shoulder levels. What was your point?
So unilateral, it could be unilateral, bilateral shoulder elevation. Unilateral could be because of massive pneumothorax, apical region, or bilateral could be because of tensed use, the use of accessory muscles, trapezius or sonoclitomus, which could be tensed up, pulling up the clavicle laterally and the raising of the elbows.
Yes, sir. Arti, you want to add something? I think somehow in the children we don't get commonly shoulder problems. The reason is, or it requires a very chronic condition, pretty a long time. I remember that we were taught in medicine back, and during that time, there was no any investigative facility, that more of the clinical things were taught. And in a case of bronchial asthma, with the emphysema of the chest, particularly in adults, those not properly treated or for the very long time with the chronicity, they may enter with you with some both the shoulders elevated. And I remember our teacher used to teach us that from when the patient enters even, you can diagnose that probably bronchial asthma and not properly managed. Both the shoulders may be elevated and it indicates some chronic airway disease. That is possible. Secondly, even similarly, on one side or so even, when you note that that shoulder right or left, it drooped a little bit at lower compared to the opposite, again that indicates some chronic fibrotic lung disease. It may happen so, particularly with the environment upper. I think again it is somehow seen in the adults. That's about tuberculosis, which is having the fibrocavitated lesions more common for the very long time, years together, and then probably more damage to the lungs. And then it may cause even fibrosis or collapse or something of very long duration, and then may present like that. But I think somehow in our pediatric patients' conditions, we don't get much. I think Dr. Reddy, any point, any information from you?
Shoulder collapse you see in this era when TB is not that prevalent in India, and asthmas are also recently well managed. If you see, and when common sense goes, the first thing is the child has some chest wall deformity or kyphoscoliosis.
Yeah.
Where it is the most common cause when someone is drooping like this.
Agree.
Common sense, then you should always think, well, the chest wall is normal. So you should strip open the child, examine properly. And if you see there's no chest kyphoscoliosis, then you can think of lung problems. But in this era now, Sir's era, probably in a lot of those cases, but right now, if you Sir is practicing, these cases of chest like drooping and collapse are very rare to see, and these cases are probably very rare as of now.
Absolutely, I will appreciate Dr. Reddy. Somehow I miss it that in children, on the contrary, that may be with the deformities. Absolutely. And therefore, any deformity with the chest, any deformity with the spinal cord, or even some other, you can note it. That can be some syndromic conditions also. Absolutely. So I think for pediatric, if at all, if you come across with this position of the shoulders abnormal, these are the conditions which you should. You know what was my point is that once you speak in the exam, you should have these ideas. Anyway, I think most of the points in the discussion we have covered. We have some time. You can go share your investigations, whichever you must have done. I think further we discuss from the investigation. Yes, Dr. Reddy, please.
The most important thing is the universal immunization program. And remember, I think in examiners are very particular about immunization schedule, what they follow. So the first question, did the child receive pneumococcal vaccine? I think if you are missed, I'm not sure if you're told that. Has the child received pneumococcal vaccine?
I'm afraid the child did not receive any vaccination other than what was followed with the WHO immunization schedule. And I think I have mentioned it in the...
Some states don't have pneumococcal vaccine. If an examiner is coming from a state where pneumococcal vaccine is given, then you'll be in trouble. So in that point, you should be very specific and tell them, so the child has not received pneumococcal vaccine.
Yeah.
Right. So pneumonia, streptococcus pneumonia is one of the common cause of pneumonia. Now you get one exam. The chances of faring well in that exam compared to other students will improve when you say, sir, this our government, like states will we don't get pneumococcal vaccine here. So that point was very important when you say. Otherwise, the most common pneumonia about the kid is now being corrected with the vaccination. Streptococcus pneumonia is the commonest cause of pneumonia in adult children. In 7 years, you still may get it. So that one point was missing. And examiners are very particular about pneumococcal vaccine.
I think absolutely with the reference to this pneumonia, the vaccination history, and very rightly he said that younger the child, suppose 2 to 3 years, one of the possibility remains of H influenza B. But now with a very good coverage, probably almost it is out of the picture. If you can, and very good coverage of this vaccine is there. And therefore, ultimately, gradually, even in the younger children also, pneumococcal pneumonia has come very prominently because still we don't have the good coverage. Of course, recently we have started in some of the states, even government of India, but still it is just at the beginning. And therefore, it is very important point that whether the pneumococcal vaccine or given or not. I think simply at least sometimes it reminds me, some examiners will ask you, what are the vaccines which can help for prevention of pneumonia?
Sir, pneumococcal vaccine,
Right.
H influenza vaccine.
Absolutely.
And these are the main vaccines which help in prevention of pneumonia.
But direct others may not be directly contributing, but indirectly contributing a lot. What are they? And even definitely, even in some other diseases also, indirectly they may be playing the role. I'm just giving the idea. Anybody?
Sir, yes, sir. Sir, measles vaccine.
Absolutely. How the measles vaccine will help?
Measles complication of measles could be viral pneumonitis, and it can contribute to it can lead to like pneumonia, viral pneumonia.
I think you must be aware that measles virus itself is less responsible for the pneumonia. On the contrary, secondary bacterial infections are more common.
Yes, Staph aureus.
And that is the staphylococcal, which may be more complicated and fatal even. It is the major factor responsible for the mortality following measles. And suppose if you are able to prevent the measles itself, that is quite rewarding for so many other complications and problems, but very specifically the pneumonia. And therefore, we can consider that measles vaccine itself is contributing for prevention of pneumonia and its complication. Viral measles pneumonia is very rare, and that is quite fatal. That giant cell, I think pneumonia is something we used to call, but now it's a different story. Similarly, any other vaccine.
Sir,
I think even with this current reference.
The BCG could be also.
Okay, BCG also we can consider. Tuberculosis pneumonia can also be prevented. But one more, viral. And the secondary bacterial infections are even again pneumococcal. And that is a fatal condition. And therefore that viral vaccine should be given every year, what we say. Which one?
Influenza.
Yeah. So influenza vaccine is also very important. And you must be knowing long back history, if you remember, that directly due to the influenza, patients may not die, but definitely following that is pneumonia itself, and therefore it is very important. Even pertussis vaccine itself, that can also contribute to some extent for these pneumonia-related problems. May not be directly but pneumonia-related problems we say, and then morbidity and mortality. So I think, and ultimately why this examiner asking the question, and I even when I'm talking to the teachers also, young teachers, I say that they should ask this question. Because pediatrician of this country should know. India, we are facing this problem. And therefore, whenever you are sitting, I will say for the practitioner, take care. Suppose if you just take care and 10 children, if you give the measures with this understanding, it's a great job. Great contribution of the clinician in this, I will say, community services. Ultimately, we should have the idea. My teacher, I remember, she used to tell, simply, we are not here to Nelson or to just present the case. Your idea that whatever you have learned, whatever you have knowledge, the ideas, then apply in your each and every patient. Simply, suppose if you give some influenza vaccine in some 100 patients of your practice, some of them, those who are going to develop the fatal complications, if it can prevent, I think it's quite rewarding. So that's the point. At present, measles outbreak is going on in several parts of the country, even including Ahmedabad, some of the pockets. And simply, I will say in your practice, if you just intensify this immunization, measles containing vaccine, it's definitely quite rewarding. So I think Dr. Reddy has raised a very good question that in the history, and I'm sure that if you mention that always examiner will appreciate that you have this idea and you have taken this point very appropriately. Thank you. And I think by multiple teachers, all of us are really contribute a lot and very important points. And I think students should be the maximum. I think Chinmay, you can share your investigations because we'll have whatever the time we will utilize it. I think exact diagnosis management will not be able to do, but to some extent, whatever we can. Please.
Sir, in vaccination also chickenpox is remaining. I think it's also
Yes,
it's also one of the, because measles and this second in this chickenpox. It's mainly you can see the most of the post varicella complications. Also.
Yeah. Chinmay, I think you can take little bit fast the investigations. Oh, sorry. Disappear. Okay, it has come. Unmute yourself. Chinmay, you are muted.
Yes, sir. So for the management part, I have managed to divide it into 3 sections: investigation, treatment, and rehabilitation. For the investigation, hemogram, differential count, peripheral smear, EPG were performed, CRP and ESR were done, blood culture and throat swab culture were taken. Also, examination, screening for Cox disease was done. X-ray, PA and lateral views were taken. USG thorax was done, and the patient improved with the treatment on supportive and antibiotics. So we had initially planned to do a workup for contrast enhanced CT scan, but we later deferred it. Sir, I have the X-ray of the patient.
Okay, you can show it.
Sir, is it
fine?
Sir?
I think I will request Dr. Hari to take this X-ray interpretation, sir. Can you take it little bit? Can you increase the size? Yes, good.
So whenever we are the interpretation the chest X-ray, there are the certain rules. First, we have to make sure whether this X-ray is really the patient we are treating. Sometimes X-ray get exchanged to each others. So first, we make sure the X-ray is that patient whoever we are dealing. Second one, first we make sure which part we order the chest X-ray. Then come to know that they are the very programmatic approach to evaluate. So grossly, actually, we don't have that much more time. So this is the basically chest radiograph showing the right-sided right middle zone or lower lobe homogeneous opacity in the right middle zone with the air. There are few air bronchograms also visible in this part.
Right.
There also something. The left side is also there the prominent bronchovascular margins. Rest of left side aeration is good, right side aeration also good, and trachea is the center, and there is the CP angle is right side is little bit obliterated as compared to the left side, and there is this side is also the homogeneous opacity in the right side in the paratracheal regions. So might be this child have the consolidation along with this minimal fluid in the right side area. That is the common. There's a common impression of this chest radiograph.
Thank you very much. I think sir has given the good points to the student to remember that somebody asked in the exam how to read the X-ray. Okay, can you go further, Chinmay?
Sir, I have the blood investigation with me. If I would like to just quickly read it. I wasn't able to upload it in the PPT.
No problem. You can read it. No problem.
So, sir, on the day of admission, the patient's hemoglobin was 10.8. BCV was 32.7. Total counts were 26,100. After which neutrophils were 78%, lymphocyte were 17%, eosinophil were 3%, monocyte were 2%. The platelet count was 549,000. CRP was raised, it was 106, and creatinine was 0.49. Serum calcium was 10.0. Sodium was 135.41. Serum potassium was 4.37. And the total serum bilirubin was 0.2. And SGPT was 5.
Okay, you have anything else?
After that, sir, on the 5th day,
any change in the investigations, count and other things?
Yes, sir. After 5 days of treatment with supportive care and IV fluid antibiotics, the patient improved clinically, and also the CRP was diminished. It was 16 5 days later, and total count were reduced to 17,100.
Okay. Anything else?
Sir, that's it, sir.
Okay, can you just stop sharing?
Yes.
I think we have few minutes, but we want to utilize it very appropriately. And for that reason, number one, choice of antibiotics. Suppose if you have diagnosed clearly with all the criteria, bacterial pneumonia or pneumonia, any pneumonia. So I think I will request Dr. Reddy, because now we will not have much time to interact with the students, that can you simply give some principles in the short regarding the choice of antibiotics in pneumonia in pediatric practice, please.
Thank you, sir. So depends upon the age. Now, when you decide on antibiotics, one, you should decide, first thing is, as a child immunocompromised patient is coming to you. So, or as an immunocompetent patient. So, for example, a patient in a bone marrow transplant or somewhere you're treating a child who was immunodeficient, you know, is primarily immunodeficient, then the antibiotic pattern is entirely different. Someone is on cancer treatment or he's on immunosuppressant drugs. Then he's
Dr. Reddy, I think mainly we focus to the community acquired immunocompetent children, which is very common in the general pediatrics.
We decided that. The next is community acquired pneumonia. It all depends upon the vaccination schedule, what is following again. Now, if it's ruled out, the second common cause is streptococcus pneumonia, right? And depending upon the age, what we see. So now, the younger the child, streptococcus pneumonia is common. As the age advances, streptococcus pneumonia incidence comes down. Okay. The other cause of pneumonia are streptococcus, staphylococcus, and mycoplasma viral infections. Right? These are the common causes. Now, viral pneumonia, obviously, you not treat it unless the child is influenza, you do acyclovir. So, most commonly, when you see a child who's hemodynamically stable, is not that sick, OP practice, amoxicillin is more than sufficient for a child. In India, as of now, streptococcus pneumonia. In West, it is very difficult. There is resistance to streptococcus pneumonia. In India, as of now, more than 90% of streptococcus bacteria are still in the penicillin group of drugs. So penicillin will work for them. Put them on amoxicillin. 5 days course of treatment, they will all improve. That is very simple, uncomplicated pneumonia. But if you think the child is not vaccinated in the school age group, then there's a possibility of mycoplasma pneumonia also. And if there's no response to initial rate of amoxicillin, and if you suspect the child is probably has mycoplasma pneumonia, then adding on azithromycin will help the child. That is in daycare practice. In OP practice, the child is not sick, you're just treating on a clinical background. So how do you think of mycoplasma? Mycoplasma incidence increases as the age actually goes. It's very rare in less than 2 years old child. As the age advances, when they go to school or college, the mycoplasma pneumonia is very high. And what are the points which in favor? Radiologically, it's not very classical, but they can have interstitial pattern kind of viral picture, but very not classical. They still present the lobar pneumonia. Two, the child may not that be sick, but it's not defined that it's mycoplasma. And third thing, which is not if you hear a wheeze in a child, that favors more towards a mycoplasma pneumonia. Viral pneumonias and mycoplasma, atypical pneumonias can have wheeze. Other pneumonias may not that have wheeze. So then some clinical points to suspect mycoplasma. And other point which can point to mycoplasma is that this child is 7 years old child and has a hemoglobin of 10.5. So mycoplasma is one of the bacteria which can cause hemolysis. So antibody-mediated hemolysis can happen. And if you see drop in hemoglobin further in the next test, if you've done, but if you see anemia in this child, then you can suspect the child has mycoplasma pneumonia. So in a crux, if you have a stable patient, first is amoxicillin, not responding, azithromycin or any macrolide group of drug would be okay. But if a child is coming to you in a very sick state, then the child does not have much time. The complications may increase. So now you are choosing to admit a patient. Now, one possibility in community-acquired pneumonia is, if you see ITSA guidelines, Infectious Disease Society of America guidelines, what they say, if a patient is coming to you sick and is an immunocompetent patient who has not received pneumococcal vaccine, then hit him hard, hit him fast. Give him a third generation cephalosporins. One, because the child is very sick. Two, there is a possibility of him having a staphylococcus pneumonia. Penicillin group of drugs may not work on methicillin resistant staphylococcus aureus. So you do not know the child has MRSA and MSSA. Unless you take a blood culture or pleural, if there's a fusion, you can take pleural culture, it's very difficult. So after taking blood culture, give him vancomycin also. And third, even azithromycin also indicated because the child does not have time. The disease will worsen. He may go on to a ventilator or any other serious condition. So when he comes to you, you hit hard with all the three drugs. Because I'm intensivist, when a child comes to me, I hit hard with 3 antibiotics. But as soon as I realize the blood culture, then I have to de-escalate these antibiotics. I have to just use one drug and treat him. So before getting investigation, the child comes to emergency very sick. Before you take a blood culture, you give all these 3 antibiotics, and after the blood cultures or reports, you narrow it down to 1 antibiotic and treat the patient. If the patient is going to necrotizing pneumonia or empyema, then the antibiotic is as based on the bacteria, and the duration is based on the complications. So this is in crux.
Thank you very much. I think he has given very, very important points. So sir, please remember, for the sake of the student, just I highlight this some of the points. By definition, once you say pneumonia, it is viral or bacterial, difficult to define exactly. And therefore, irrespective of viral or pneumonia, every patient of pneumonia should be treated with the antibiotics. That's very basic principle. Second, what Dr. Reddy made the very important point, that as a whole, immunocompromise is a different situation. Right, that we should keep it. I think as a general pediatrician, if we remember this much, it's more than sufficient. That it should be managed very appropriately with different immunocompromised status with the experts or some, I would say, person should be known for tackling this situation. Once you say community acquired pneumonia, if it is very stable patient and presents to you with this pneumonia, very rightly he said that you can start this amoxicillin also. According to age, here and there some changes. Again, pneumonia, hardly even in the base centers, in spite of a blood cultures, you may get 8 to 10% positive. Most of the times we are not able to define or able to get the etiological agent, right? And for that reason, epidemiologically, what we have devised in the science, according to the age of the patient, we have defined some groups, and accordingly, even possible organism most common, and then according to choice of antibiotic. That is the second principle. Most of the children community acquired, if you have chosen the appropriate antibiotic and given, and compliance is good, in 48-72 hours, we are expecting to get the clinical response. In the form of the fever may go down, increased work of breathing may go down, child may feel at least being good, may start even take orally, and these are the signs of well-being or improvement. Not necessarily everything will disappear, but consider that this is also signs of improvement, and there is no to go for further any change of antibiotics or anything. But 72 hours, on the contrary, rather than showing the improvement, if the patient is deteriorating, most of the times what is seen in the practice, to chase with the antibiotics. I think that's not the right answer. On the contrary, first, very common to confirm the complication. Because the complications are more common, what not responding after 3 to 4 days of antibiotics. And for that reason, usually we don't go for the repeat chest X-ray, but here you should. If it requires, even you should go for the ultrasound, detect early or even detect the minimal collection of fluid, which is more common. Or here is some going for necrotizing pneumonia or developing lung abscess. These are the empyema. These are the most common complications. And complications are there with the surgical intervention if it is indicated that antibiotics will work. That is very important. I think resistant problem is there, but it's not so common. Not so common in our routine practice. So I think that we should keep in mind. And that is very important. And accordingly, you can go for further workup or situation, whatever you are facing regarding mycoplasma and everything, very rightly said. And therefore, I think, but as I said, routinely we may not go for the blood culture, but what Dr. Reddy said, severe pneumonia, I think, and critical patient, blood culture is very important. And now the here concept of antibiotic escalation and de-escalation has been changed. Initially, what we were doing, that start with the basic antibiotics. If not responding, then go for the escalation. But now, later on, we learned that in this critical patient, it's not right approach because mortality is high if you are giving the chance to this organism. And therefore, now what he said, that hit hard from the beginning in these patients. But please remember, only critical patients, not your routine practice. And critical patient, therefore, according to the circumstances, possible organism, possible complications, possible host, you can go for the choice of antibiotic, which will hit very hard. And later on, as per your culture or some other clues, you can, if required, suppose if I am thinking for MRSA, but now I confirm that it is MSSA, then probably I should go for the de-escalation from simply cloxacillin. It's going to work. So I think that's very important point which we should keep in mind. I think, sir, Dr. Hari, you can take a few minutes that what are the common complications in these pneumonias, which the students and everybody practitioners should know. Common complications.
Yes, sir. As we have seen this patient has a lower pneumonia along with the parapneumonic effusion. So the commonest complication of the pneumonia is the parapneumonic effusion. Second one is the very common is the empyema. It depends on the etiological organism, but empyema is also is common second due to the complicated pneumonia. Later on, sometimes it turns out to be a lung abscess, or sometimes it can lead to the pneumothorax. So basically, 3-4 complications are very common: effusion, empyema, and lung abscess and pneumothorax. So it's depending on severity of disease, depending upon involvement of the lung parenchyma, sometimes these can happen in the pneumonia cases. And as we have seen in the investigation part, we must understand the CBC, ASR, and CRP. Actually, they usually not tell you about the etiological agent which is causing the pneumonia, neither they tell you about the severity of disease. So usually sometimes you're wasting your time to by catching these kind of investigations. That the time is very precious. These kind of investigation can be useful for the monitoring of the disease. There is no role of the diagnosis. There is no role of the selecting the antibiotics. So pneumonia is the clinical diagnosis. Try to make the clinical diagnosis. Find out whether it is a complicated pneumonia or non-complicated pneumonia, and just choose the antibiotic depending according to the clinical severity and depending upon all the age of the child. Second one, the blood culture. Sir already said that there is no means of the blood culture in the non-complicated pneumonia. That is very yield or blood culture is very low. And similarly, there is no routine scope of the CT scan. On CT scan, you only can play out the role on in the complicated pneumonia. If you are suspect there is a complication of the pneumonia, if your child is not responding, or there is a possibility of the some other differential diagnosis, then you can help with the CT scan. Otherwise, routinely there is no role of the CT scans as well.
Absolutely, absolutely. I think within this short time also, but he has given the very golden sentences. Number one, pneumonia is a clinical diagnosis. Absolutely, sir. Please remember, And even the unnecessary X-rays also, what we are doing in the practice probably may not be indicated. On the continued radiological shadows are going to take very long time to disappear. So in a responding patient, probably does not require. If you are facing the problem, expecting some complication, and for that reason also very nicely he said, for the fluid, sonography is best. But if you are suspecting some necrotizing pneumonia or lung abscess, I think in that case only you will go for the CT scan. But otherwise CT scan is also not this proper answer in all the complications. Very rightly sir said. And then how to manage and culture, he made the points very clear. I think last question to the students. Suppose in this patient, you diagnose appropriately, treated the patient, even responded. And as we discussed that we don't go for the repeat X-ray chest in the responding patients, with this appropriate, even the from IV to oral you switch on, and you discharge the patient. And patient was well and fine. Again, the patient came Chinmay to you. And again, this repeat chest X-ray shows even this pneumonia. What will you do? Or suppose in other way, I will say that was somebody has repeated chest X-ray. It was just the opacity was becoming very faint, almost going to not totally disappear, but about to disappear. Now again, it has come with the same dense opacity of the pneumonia. And as you have shown, even location, let me tell you, that at the right middle is, and that is rounded even. Now I could see that this obesity is rounded. And then pneumonia, even somebody will say, mother will say, parents will say, yes, sir, in the district place, we have treated 2-3 times this pneumonia. And the pneumonia happens only on that side, right side and middle. And we are giving some antibiotics, patient improves, we are discharged, but this is 2 or 3rd time. And when now it has come to the Surat Medical College, and now you have seen that it is a rounded opacity and right middle lobe. And child is not 7 years, but suppose younger the child, 2-3 years old child. What will be your differentials, or just to give the thoughts? And what can be even in a 7 years old child? Suppose take both the groups. I said it is rounded. Arti, any condition comes to your mind?
Sir, if child is younger, like 2 to 3 years of age, we should suspect in the direction of foreign body. Because,
okay, very good, very good. I will appreciate. I think first the foreign body. Okay. May not be, I will say that lobe or anything, but always the foreign body. Absolutely fine. Anything else?
Sorry.
Yes, Sachin, because I want to sensitize you, to at least stimulate you.
For an older child presenting with a circumscribed mask, I would think for lung abscess.
Okay, but in between it disappears. There is no lung abscess. Even the opacity becomes totally faint, does not disappear totally, but and then it becomes a very rounded opacity. I will say it is cystic swelling. Let me even clarify. It is cystic swelling in a older child, and the patient is coming from Jamnagar.
Sir, could it be hydrated cyst, please?
Absolutely right. Somehow Jamnagar, I think you should be we are not having exact, but the coastal area, hydrated cyst is common, older child, and multiple cysts even may get. But suppose it's only 2 years old child, 1.5 years old child, and shadow is at this right middle lobe, and it is congenital. Then what can be the congenital?
Could be a bronchogenic mass.
Absolutely. Now this another shadow is left lower lobe, develops recurrent congenital malformation. What it can be? Arti, Chinmay, anybody? I think Chinmay answered very rightly that right, particularly this middle area, if you are getting hilar area, that is the most common site for the bronchogenic cyst. Absolutely right. Similarly, another patient develops, that means common site for the congenital malformation of the left lower lobe. And that I could prove by aortography or some investigation. Then what it could be?
Possibly, sir, could be an aneurysm or vascular ring.
Okay, it was not aneurysm. It was lung problem only. Okay, that's also a good point, but it was not vascular problem. But this in short malformation related to the pulmonary system, but somehow it is having some different type of vascular supply, and therefore I went for this, and ultimately I diagnosed. And it's a congenital malformation.
Sir, can it be pulmonary AV fistula or something like that?
Okay, Arti, I made the point clear that it is not vascular, it is pulmonary problem. On the very students are thinking very good. Vascular malformations also maybe the one. Pulmonary sequestration.
Sir, could be sir hematoma.
And anatomical pulmonary sequestration is common even, it can happen, but you know what I wanted. And another like pneumothorax appearance, but it is well localized and left upper lobe. And it is congenital. What it can be?
Congenital cystic disease of lung.
That's a little bit different. Here what I said, it is a hypertranslucent area, well localized. And there is a herniation of the mediastinum on opposite side in X-ray. And that is on the localized only left upper lobe. And it's a congenital. And answer is to resect it. Patient will be all right. And answer is congenital lobar emphysema. Yeah, just to sensitize, and you know, suppose in the exam you have the good performance, the examiner may go for these other questions, may not probably daily in our practice, but yes, we come across. So I am not pulmonologist, I am general practitioner, pediatrician. But if somebody asks me, yes, all the conditions we have seen in the practice and operated. So the point is, when you are facing the problem, go beyond that. You know, horizons of your thought process should always be kept in mind differently. I think this is just to sensitize the student. We'll have to end over here because we are overshooting the time very long. Somehow everybody has tolerated us, even the Dr. Nehal and even these persons who is operating and telling us. Thank you very much. We will end over here. Dr. Nehal, now it is over to you.
Thank you so much, sir. It's not a tolerating, it's always a joy to hear you in case presentation. And so do we have any question on YouTube?
I think before that, let me appreciate both these, I will say, experts, Dr. Reddy and Dr. Hari. In the true sense, I learned a lot from both of them. That this is very important, and how best even we can utilize, even in spite of their specialization in some field, they are starting from even the basic like me. Otherwise, I feel that I am the basic pediatrician, general pediatrician. So I will start from the thinking of only general. Probably these fast developed areas may not be of my purview, but somehow I'm learning from both the experts. Really, I learned a lot. Thank you very much, both of you. Please.
We learned a lot.
Yes. So thank you so much. We don't have any question on YouTube. And for today's session, I really thank everybody, especially our two experts, Dr. Reddy sir and Dr. Meena sir, for your constant guidance in the case to the students, and also to the students, and especially Chinmay, to get all the things and to make the case interesting. It just interesting in discussion also, and to present it very nicely. Other students to participate, and many thanks to sir for guiding the students from basic.
Neil, you are muted. Neil, you got muted.
Yeah. So thank you so much, sir. So guiding us in the journey.
Before Neil ends, let me appreciate Chinmay. Definitely, you have done a fantastic job. You have taken the history, I would say, beyond even the details. Certainly, it's a good part. And it requires, I would say, details of the history and even the lots of the pain to collect all these informations. And you have the very good selection of case, and presentation was really fantastic. And I should appreciate Aarti because she stood with you. She was there even to help you. And she has, I will say, interacted very nicely. She responded even to several questions very appropriately. So both of you, and I'm sure other students, due to the shyness, they have not come out, but I'm sure the next time they will. And I'm expecting that more students should be on the screen, so all of us can learn. Of course, students will learn more, but we are also learning. Thank you very much, Dr. Nehal. Go ahead.
Yes,
Sorry
sir.
for interruption.
Yeah, so thank you so much, sir, for taking us for the journey from basics to advances. And I thank everyone and also the Clarinet platform for giving us this support. Thank you so much.
I think Dr. Praful is silent,
yeah.
but the silent factor is a very
Yes,
good
yes,
force.
yes.
It's a very good force.
Sorry, Praful. I forgot to mention, but
No
yeah,
issue.
good. A very nice mentorship, and you were there throughout to encourage your student for because a presence of the mentor matters a lot. Yeah.
Yes.
Thank you, ma'am.
So, sir, let me clarify here. The doctor, actually, the other system planned this Saturday, but due to some reason, some conference is going on, so experts are not available. And Chinmay agreed to present this case at the very short notice, only the 3 days. And he prepared the case yesterday midnight, and I sent PPT to experts and Nehal madam, because very short notice, the case is not ready, patient is not there, even though he prepared everything within a short while, and he presented excellently. So thank you, Praful and Chinmay, and thank you very much, both the experts. They also agreed very short notice, Dr. Reddy and Dr. Hari, and they have guided very well. And always, or Baldev Prajapati sir, need not to mention anything about the sir. So thank you very much, sir. And Dr. Arati, be assured you are the good student, and you are always with all the students. Those who are presenting.
Yogesh, I think she is the next presenter.
Yeah.
Thank you so much, sir, for helping us. Thank you so much.
Thank you, sir. Thank you.
Thank you. Good night.
Yeah.
Good night.
Yeah.
Thank you.
Let
Good night,
us meet
sir.
on next Saturday.
Good night.
Yeah.
Yep.
Thank you, sir.
Thank you.
Thank you.
I think so, sir. No commitment for the next Saturday, Prajapati sir. No any other academy program.
Next Saturday, I'm at Mumbai.
Yeah, that should be clarified.